right now, our hands are tied and limited by our payer community, in that it's restricted, if you will, in the majority of cases, overwhelming majority of cases, to patients who have failed multiple immune therapeutics, even though the FDA approved it for generalized myasthenia without restriction. The REGAIN trial originally used refractory patients, those failing multiple ISTs. Ravulizumab and others in the pipeline, like zilucoplan, don't have a restricted study population. They're being used in all comers. We don't have good data yet as to whether there are differences in response, whether one has short-acting disease versus long-acting disease, the number of prior ISTs. That's all forthcoming as we follow these patients and do our data digs. But my future shows that complement will be used much earlier in the course of treatment than we're currently using it, in part because we hope it won't be restricted, but also because it's quite efficacious. Why let your house be destroyed by a hurricane and have to rebuild it? Let's protect it from the start. And as you know, complement acts at the neuromuscular junction through the membrane attack complex, which literally drills holes through the muscle membrane, leaks its content, and the muscle fiber is no longer functional. So if we can protect it early in the game, then there's the potential that we'll have a much better, deeper, if you will, more prolonged beneficial response. In doing so, we still have to deal with the antibody, because the antibody is still circulating around. And my future prediction is that we will begin combinational therapies with something like complement plus an FcRn, or something that addresses antibody production through B-cell depleters, et cetera. And I think we'll see a culture shift over the next 10 plus years to stop using our broad spectrum immune suppressants with their significant adverse event profiles and start using targeted therapies such as complement inhibition, FcR inhibition. And my belief is in combination.